will discuss more on colorectal cancer and the various treatment modalities, Professor Mallika Tewari. Professor Mallika Tewari is a senior surgical oncologist with expertise in hepatobiliary and gastrointestinal surgical oncology, and she is currently the professor and chief of the HPB and GI division at Institute of Medical Sciences, Banaras Hindu University. Dr. Tiwari has over 2 decades of experience in surgical oncology, having trained at world renowned institutes like Johns Hopkins Medicine, Mayo Clinic, MD Anderson Cancer Center, and University of Heidelberg. Her dedication to advancing patient care and her contributions to the field have made her a respected figure in the medical community. We are privileged to have her here today to share her knowledge that undoubtedly will enhance our understanding of current treatment practices. Welcome, Doctor, to our event.
Thank you. Thank you so much. Thank you for inviting me.
So, Doctor, let's start with the basics. How prevalent is colorectal cancer in India or worldwide, and what are the common symptoms of this disease?
Okay, so colorectal cancer unfortunately is growing in our country, and these are certain statistics that I wanted to put out for everyone to understand that how grave the disease is becoming of late. The annual incidence rate is calculated. The number of patients that you see is about 5.36 per 100,000 of normal people, the normal population of the country. But it's still far low as compared to those cases that are reported from the West, where it can be as high as 66.2, like in the US. But the problem in our country is that the incidence and the prevalence rate is rising, whereas in the West it is showing a declining trend. And I can tell you that as per the data, there are various agencies that collect this data, and it is estimated that about 65,000 patients were reported to have colorectal malignancy in the last 2 years. So it's quite an alarming figure. Colorectal cancer in our country is seen more often in males and around 50 years of age. And if you look at the world data overall, the lifetime of developing colorectal cancer is in 1 in 23 for men and 1 in 26 for women. These are the Western data, not in our country. So it's definitely increasing, and it's an alarming figure for us.
Okay. And what are the common symptoms for this disease?
Yes. So as we know, before we go on to the symptoms, we must know the risk factors. Who are more likely to have colorectal cancer? Less than 20% are familial. Familial means that somebody in the family of the first degree relatives is having colon cancer. The likelihood of colon cancer developing in the other siblings is very high. So, but it's still roughly about 20% of all cases that we see. There are some bowel inflammatory diseases that patients do have, chronic problems of ulcerative colitis and Crohn's disease, which over a period of years, about 10 years longer duration or so, can have focus of cancer developing into them. Then the most significant is the part of our diet where there is red processed meat compounded with smoking, alcohol, uncontrolled diabetes with sedentary habits resulting in obesity and lack of physical activity. All these combine together as one of those important risk factors for the disease. Now, how do we know that somebody might be harboring a colon or a rectal cancer? The most significant finding is passage of blood in stool. Now, it is important to understand that this bleeding is usually painless unless the disease has advanced to a great extent. So, any kind of blood in stool must ring your bells, and you must visit your doctor rather than thinking it's a simple hemorrhoid or something. Let the doctor evaluate. Right? And then there might be change in your bowel habits where it can be, you may have constipation, thin caliber of stool, and over a period of time, if this continues, then there will be loss of weight, and you wouldn't like to eat, that we call loss of appetite. So all these are features of advanced cancer, and sometimes when it advances to such an extent that the whole intestine gets blocked, then you are unable to pass stool or flatus, and there is abdominal distension, and it's a medical emergency.
Okay.
So yes, it does show warning signs before.
Okay, so you mean abdominal discomfort, and especially if there is blood in the stool, one should definitely take note of it and
Right.
visit the doctor just not to take any chances, and in case they can detect it at an early stage. So is
Yes.
this detection at early stage possible, and what would be the significance of detection at early stage?
Like you were just discussing before we started talking about the various screening methods. In India, we do not have any screening protocol for any cancer as of now. And especially for colorectal cancer, because the incidence is not that high, screening the entire population would not be justified.
Yeah.
But still, if there is a strong family history, as I say, like we have many patients who the father had colon cancer, then the patient has colon cancer, and the siblings and the children also have polyps, which are precursor of cancer in many patients. So
Hmm.
as you can see in this diagram, the first diagram that shows a tube-like structure, which is a colon, and there is a tumor which is growing into the colon. So there are various stages of cancer. And this is a real colonoscopic view where you can go to the next slide, please.
Hmm.
So as you can see in the initial stages, there is that yellow marker that shows a small cancer which has started to arise in the normal epithelium. Now this is not going to give you much problem other than occasional bleeding, right? But what happens if that is neglected? In majority of patients, it will blow up and grow into something like this, and the opening in the lumen has reduced to a significantly lesser size, and eventually it may get blocked. So that is when we say that the patient has developed obstruction due to cancer. And besides screening that we do in asymptomatic population, once you have some problems, then you must visit your doctor, where he or she will take a thorough history, do some clinical examination. And by far, the gold standard of diagnosing and staging the disease remains colonoscopy, as you rightly mentioned in the screening thing also. It's just a tube where you can see in the last fourth photograph down there, it has various channels for enabling us even to take biopsies. And sometimes some polyps can also be snared out. All polyps are not cancer; they are mostly precursors of cancer. So if there is any suspicious looking polyp, it can also be removed. So colonoscopy can only be diagnostic and also therapeutic in certain circumstances. And once
Okay.
we have a diagnosis of cancer, we take this biopsy, examine under a microscope to be 100% sure that it shows malignant features. Then there are various imaging like CT scan, endorectal ultrasound, MRI, as the case may be, to stage the disease and then subsequently manage.
Okay, understood. And as with all other cancers, the more early it is detected, there are better chances of treatment.
Definitely. Yes, yes. It's one of the cancers that can be really cured. There are very few cancers which we really cure in, you know, as an oncologist.
Okay, that's good to know. So people should obviously pay heed to the symptoms as soon as they appear, and like you said, if it can be cured, nothing like it. But
Yes,
precursor is it needs to be detected at the early stages.
right.
Okay. So what are the current standard treatment options for colorectal cancer?
So when we say colorectal cancer, it's basically two parts. It's the large intestine, which is called the colon, and the terminal portion of the large intestine where it opens out into the anal opening. It's called rectum. So
Hmm.
the cancer that occurs in both the places has certain similarities and certain differences, and the management is also quite different. So if the tumor affects any part of the colon, there are various segmental resections we do, and that's called colectomies. The right side, right colectomy, and things like that. There are various nomenclatures. And when it comes to rectal cancer, now there is a problem there because many a times the anal sphincter is there, and we try our best to preserve that anal opening, because otherwise, if that tumor affects that area and it has to be removed, then there is a problem because the anal opening is permanently closed, and an opening is made into the abdominal wall that is called a stoma, or a permanent colostomy that the patient has to live with for his entire life. So the management is greatly different. And then there are certain complications which are inherent with rectal cancer surgery because of its location down deep into the pelvis and the surrounding nerves that supply the bladder and affect the micturition and sexual functions of the patient.
Okay. So that means that the suitable treatment approaches can be determined only based on individual patients,
Right,
considering factors like the location or age or even the stage of the cancer.
definitely. Definitely. So, like I
Okay.
was telling, this is the picture that shows
Mhm.
the colon, and depending upon where the tumor is, see that there is written right hemicolectomy, the right half of the colon. Now, it is important to understand that in cancer surgery, it's not the diseased part that is resected. The lot of healthy part is also resected, and all the draining lymph nodes are also removed. So it's not only
Okay.
lymphadenectomy; it's a proper lymph node resection that is required in any cancer surgery, and so it is here as well. And
Mm.
sometimes, in certain cases, when there are multiple focus of tumors across the colon, that also happens, and that's especially seen in hereditary cancers, where we have to remove the entire colon. As you can see in the operative specimen, the entire colon has been removed. So this is how we resect various colon cancers. And for rectal cancer, as I was telling you, nowadays we have various kinds of techniques available and various stapling devices in which in almost 90% of the patients, 95% of the patients, I should say, we are able to preserve the sphincter function. So with the help of these stapling devices, we are able to go deep down into the pelvis and join the two ends together. And unfortunately, if the tumor is such that it really involves the sphincter, then we are left with no choice but to remove it in its entirety. That's called an abdominoperineal resection. We can have the next slide to show that. And in that case, as you can see, the anal opening has been closed. Here, the tumor was too advanced and involving a lot of area in the perianal region also, and that required a special flap. This is a tissue taken from other part of the body to cover the gap once the tumor was resected. And then the patient has a stoma, which is called the colostomy. And you can see in the diagrammatic representation, there is a bag which is fitted over it, and the stool comes and collects into it. Now, this is a very important and significant change in a patient's day-to-day activities, and they really need stoma care specialist and some kind of counseling to handle this situation.
Okay. Okay. So in this case, as I can understand, the organ was not preserved, and they have external bag in which
Right, right.
thing are
Now,
collected.
yes, this is just to show that colon cancer is one of the cancers which is treatable even if it has spread out of the colon. And in this case, the most likely place it goes out of the colon is through the bloodstream into the liver. And
Hmm.
even in these patients, it's a carefully selected group of patients in a multidisciplinary setup where we use chemotherapy, radiotherapy on an individual patient basis. And selecting out patients who respond favorably, we can even go ahead and remove a liver, part of the liver, or multiple times we can do these kinds of surgeries. In this patient, as you can see, there was a tumor which had gone into the liver. We were able to resect that part of the liver. The patient really do better than any other cancer which has spread to the liver otherwise. So
Okay.
it's a good cancer as far as we are concerned. We are able to treat it to a significant extent, even in advanced stages.
Okay. That's
Right.
that's good to know. And what you have explained till now is the role of surgery in removing parts, organs. But there are also some non-invasive techniques nowadays, like minimally invasive approaches, I should say, rather like laparoscopy and robotics. How are they playing a role in surgery and like the treatment, like you said?
Yes, so the basic thing that one must understand is that the surgery remains the same whether it is done by an open method or by use of minimally invasive surgery. The only problem is that in an open surgery, we have a large incision and it significantly adds to the morbidity of the patient. But still, an open surgery is sometimes required in very large tumors or when the patient is in obstruction where laparoscopy or robotic approach is not visible or the expertise is not available. So
Okay.
what essentially is done in laparoscopic surgery is there are multiple holes as you can see in the diagrammatic representation. One is a simple midline incision, a long incision is there, and in there, and the other adjacent photograph, there are multiple small keyhole points. So through these, the instruments are inserted and the same surgery is carried out by the surgeon. And in robotics, what happens is that the surgeon is sitting at the console, and there is only one or two assistants which are actually by the patient's side. The robot does not do the surgery; it's the surgeon who is doing. And this robot gives us the advantage that it has a wrist-like movement, so we are able to maneuver deep into the pelvis, and the visualization is very good. So the nerve problems that occur, the damage to the nerve that occur in deep rectal cancer or a prostate cancer, they are minimized because we are able to visualize them more clearly. and because the imaging that we get is magnified 2 to 3 times. So that way, patients' morbidity as far as this is concerned, these kinds of surgeries are concerned, can be minimized. And then it also translates into quicker recovery, as per the studies say. So if the expertise is available, the disease is not very much advanced, I think minimally invasive surgery is here to stay for colon and rectal cancers.
Okay. And when we use robotics or other minimally invasive surgery, like you said, it also helps in reducing post-operative complications.
Yes.
It will not be an open surgery and lesser chances of infection.
Infection, I wouldn't say, but yes, the morbidity that arises because of pelvic nerve damage is minimized, and it definitely enhances recovery because the pain is less, and it's easier to dissect out. Because what we do in these procedures is that we insufflate CO2 into the abdomen, so the abdomen gets distended, and when
Mm.
we dissect, all resections in cancer are in certain planes. So it enhances our resection through the planes. So it all the pneumoperitoneum that is caused artificially for these surgeries also helps in dissection and minimizing bleeding. So all these results in faster recovery, less pain, and easy discharge.
Okay. Doctor, a few minutes back, you were talking about the role of multidisciplinary approach, especially when the colorectal cancer has metastasized and moved to other organs. So, what are the potential benefits and challenges in combining the different treatment modalities like chemotherapy, radiation therapy?
So what
Any,
we,
yeah.
yes, sorry, please complete it.
No, I was just saying, can you shed some light on this comprehensive treatment plan that is suggested to the patient when they have the need for a multidisciplinary approach?
So one must understand it very clearly that cancer is not any one person treating the disease. In almost every cancer today, we need solid tumors. I'm talking about, like solid tumor. I mean that tumors that affect any organ system. So most of these cases require a surgical oncologist, would require a radiotherapist, and would require a medical oncologist. So all these three form the main basic tripod. Along with it, we have to have a dedicated radiologist, a dedicated pathologist. Sometimes in GI cases, we need a gastroenterologist, nursing care, nutritionist, because without the interplay of all these people or the team is unable to function. So as
Hmm.
far as this colorectal cancer is concerned, again, this requires, whether it is in early stage, whether it is in late stage, it doesn't matter, but a multidisciplinary teamwork is always there. In
Okay.
majority of our patients, like when they are node positive with a low rectal cancer, we give them something which is called as radiotherapy prior to surgery. Now
Hmm.
that enhances our margin clearance rate. That means that every time we take out the tumor, when we do a histology, the margins where we cut, they should not be harboring any cancer cell. Not a single cancer cell should be on that area. So
Okay.
in certain tumors where the chances of having an R1 resection or leaving behind tumor is significant, we need to give some treatment prior to surgery. So again, the interplay of all the colleagues is very important. Definitely.
Okay. So definitely, whether even in early stages, sometimes a new adjuvant therapy is required,
Right.
where you give a radiation therapy, like you said, so that the tumor shrinks, and then you have better chances of
Right.
operating there.
Right. Right.
Okay, understood. And even in one of the images that you showed, there is a colostomy bag that needs to be inserted. So I'm
Mhm.
guessing in many cases it is not possible to preserve the bowel and urinary function.
So,
Can you
yeah.
tell?
So, what happens is in a low rectal cancer, minimum of 1 centimeter margin is necessary. Otherwise, if you are too close, there are chances of the cancer coming back is very high, and then the entire effort of preserving the sphincter is totally lost. So
Hmm.
what happens, like in this figure, you see the tumor is fairly high, but sometimes it is quite low down in the anal canal. And in the anal canal, what the sphincters we have, there is an external sphincter and there is an internal sphincter. And we can even resect a part of the internal sphincter. But suppose the tumor is, in a way, it has invaded so deeply that these sphincters are already destroyed or deeply invaded, and they cannot be salvaged no matter what you do, then the best treatment option is an APR, which is still better than having a recurrence low down there and not being able to do anything. So I think the decision always lies with the expert surgeon who is treating, whether to go ahead with an intersphincteric or a very complicated low resections are also very difficult surgically, but also what happens is post-operatively they do not function as a normal rectum. The normal sphincteric mechanism is never there once the tumor is low down and it has been resected and radiated. So you have significant problems of stool soiling. Okay, and they are not able to hold multiple times. They have to go to the washrooms and all. So we really need to counsel the patient and look at them whether they will be able to, like a 85-year-old coming with very low rectal cancer may not be an ideal candidate to have an intersphincteric and a very low kind of a resection. We will do better off with a permanent stoma. So like that, we have to really reassess and counsel and then decide upon which is best for the patient.
So the counseling is a very integral part of your post-operative care, and the
Right,
patient should
right,
not skip that.
right. Because everything, the nervous play, it's a very complicated process by which the defecation actually occurs. So all that the continuity is lost once we are doing a resection that low down into the rectum. So definitely that's important not to just restore the continuity, but to be able to carry it in the day-to-day life. The quality of life of the patient should be good.
Okay, understood, understood. Nowadays, there are a lot of newer techniques that are coming in, like integration of 3D imaging, navigation system. How is that helping you in your surgery procedures?
Uh, Actually, in these 3D imaging, etc., we are already doing it in all cancers, and it's more helpful in hepatobiliary, where the dissections are very complex. In colorectal cancer, they are doing it. We also do it sometimes, but not in all cases. It could be like in a recurrent tumor or where there are deposits outside the pelvis where we need to really know the location and if we will be able to resect them. But yes, the 3D modeling, as you can see in this photograph, it's a model. You can also have a 3D imaging that plays out on your console. It's really a reconstructed image of all the CT scans and MRI that we do. With the help of certain softwares, it can be made to look, you can just rotate it 360 degrees and find the exact location. So you are mentally prepared that the tumor is sitting there with these structures around it. But and sometimes they also make out these models where you can really appreciate where the tumor is. But in colorectal, it's people are doing it some at some centers, but it's still not all that beneficial, I would say, for all patients. Maybe in the selected group of patients. The importance here is to safeguard the nerves, as I showed it in the previous slide. There is a large number of plexuses that surround the rectum, and damage to these nerves causes lots of problems. So 3D imaging and laparoscopy and robotic surgery, they really help us to visualize these nerves properly because they are magnified and it's easier to save them. And now we have different kinds of lighting techniques also in laparoscopy also they are available, which help us to identify these nerves even better.
Okay.
So likewise, they are helping.
Okay. So there are already, I'm guessing, many such emerging techniques and ongoing research to further refine your surgical techniques. So I
Yes, and most
you
of them are centered around the nerves, preservation of the nerves, and then individualized treatments where they look for cells circulating cancer cells in blood, and then they tell whether the how the patient is going to do after surgery and chemotherapy. So that's called liquid biopsy, circulating tumor cells. It's an
okay.
era of personalized medicine which is approaching
Yes,
sooner
yes.
than later.
Yes. So every treatment modality has to be personalized based on the patient's individual need. So that
Yes.
is where we are heading, definitely. So, doctor, as we are nearing the 30-minute mark for our event today, do you have any last words to say to our patients regarding colorectal? Because you said that it's a curable disease. So, what are the things that should be kept in mind?
Oh yes, if there is any symptom which is altering, which is not as I mean, it is something different from what normal is. Like you have bleeding from anywhere, any tumor which is growing, any lumps and bumps, any ulcer in the mouth. I'm speaking in general, not only in colorectal cancer, which is not healing, but it may be painless. All cancers are painless to start with. So anything that is other than your routine, you find if the bowel habits are routinely not proper, if there is a chronic cough which is not subsiding despite treatment. So all these should alert you and you should visit your doctor and seek consultation before deciding for yourself that there is nothing. Now, most of these cancers are caused by tobacco taken in any form, especially smoking and also alcohol. And if you talk about colorectal cancer itself, smoking definitely adds, though we do not really know exactly how, but it definitely goes to the various chemicals. See, there are about 4,000 chemicals, 70 carcinogens in tobacco smoke. So whether it is passive smoking, like you are smoking, but other household members are also inhaling, so they are also getting affected. So these are very serious things because they can go inside and cause lots of genetic damage. Also, alcohol is the number one carcinogen. If best if you don't take it, but you should limit it for less than 30 grams a day. There are some studies suggest that. It definitely adds to the colorectal cancer risk. And then we have always recommend that you eat lots of fresh fruits and vegetables because they are having natural antioxidants and avoid processed red meat. That is one of the main causes of colorectal cancers. And also maintain a healthy weight and lifestyle. Keep your diabetes in check because insulin resistance and high insulin levels, the insulin itself is a growth hormone kind of a thing. So in hyperinsulinic states, diabetics, which the diabetics have, they also result in having cancers which are more aggressive. And as I said again, we'll conclude by saying that regular check is very important and any deviation from the normal routine should always take precedence and you must visit your doctor.
Yeah, thank you, doctor. These are some wonderful insights that you have shared with us. Your expertise really, we have learned a lot, and we
Thank
appreciate
you.
your time and valuable contribution. Thank you so much, doctor.
Thank you. Thank you so much. Please take care. Bye.
Thank you. With this, we come to an end to